In this lecture, we're going to talk about calling up admissions and consults. I remember my first consult. It was the first day of my intern year, and my resident told me to call ID to consult on a patient who had pneumonia. Halfway through the consult, the ID consultant stopped me and said, "It's that time of year again, isn't it?" I could just visualize a person on the other end of the line shaking their head with their forehead in their palms. As I think about it now, it makes me laugh, but back then, it made me feel really dumb. And it was at that point that I started constructing a method to formalize how I would call up admissions and consults. I used all the advice that I got from the attendings that I worked with during my residency and came up with this approach. So hopefully it'll help you as you start calling up admissions and consults. The main thing to remember if you're getting pushback is that there may be a failure to communicate effectively. Be precise with what you say. Think about what your consultant or the admitting doctor may ask you prior to calling them, and be prepared to give them an answer. So with all that said, let's go ahead and begin with the template. Your first line of your consult or admission is the most important line. Unlike when you're presenting during rounds, you want to be upfront with exactly what this patient has. Don't start with a chief complaint and go down some nebulous history and physical to get to the punchline. The person on the other line wants to know exactly why you're calling them as soon as possible. So with this in mind, I recommend the following template. Hello, I have an admission or a consult for a patient with a specific diagnosis. If you can, you then want to add who needs to be admitted based on this criteria. Putting the criteria or the evidence-based medicine into that first line will really anchor to the consultant that there's no room for any pushbacks or question. So for example, you could say, hello, I have an admission for a patient with syncope who meets admission criteria based on the ACC-AHA guidelines on syncope. If you're calling a consult, you also want to be very specific with what you're going to say in this first line. For example, you would say, hello, I have a consult for a patient with CT-confirmed appendicitis. I can't emphasize enough how important this first line is. It sets the tone for the rest of your presentation and tells the person on the other line that you know exactly what's going on. Once you nail this first line, the rest of the presentation will be a breeze. Your second line of the consult will be to give the patient's name and medical record number. The third part of your presentation will be to give a very precise and pertinent history. We generally give a lot of information when we present on rounds, but remember, the whole goal of admitting or consulting would be to get on and off the phone in 20 seconds. So you want to be very precise with what you include in the history. It should be very focused and supportive of what your diagnosis is. Be careful not to introduce additional information that may not be pertinent to why the patient is being admitted or consulted on. For example, when you present the first line of your history, generally people start by giving a laundry list of past medical history. Only include the past medical history that's really important. Does your patient have a wild card, like they're immunosuppressed, they're anticoagulated? If you're calling up a surgical consultant, be sure to know what the patient's past surgical history is and include that in this part of your presentation. You want to speak the language of your consultant. Think back to your med school rotations and remember what were the parts of the history that the consultant cared about when you were rounding. Again, going back to the surgical consultant, you'd want to make sure to know when the patient's last bowel movement was and if they're passing flatus, and a patient that you're consulting for a possible obstruction. Part 4 will be the physical exam. Start with the vital signs, and then give a very focused physical exam. For example, if you have a patient who has appendicitis, you really just want to spend time focusing on what the abdominal exam looked like. The patient's neuro exam would not be pertinent in this case. The next step would be to review the patient's labs that are pertinent. For example, in a patient who has an upper GI bleed, it would be really important to mention what the patient's hemoglobin is, what their platelets are, and what the INR is. This way, you're not wasting time listing off labs that really are not pertinent. Going back to my ID example, I should have been more prepared by reviewing all of the patient's cultures and CBCs. The next step would be to go over pertinent imaging. Finally, the last and most important step would be to go over what your interventions were that you performed. You probably just didn't sit there and look at your patient. This is important because if you did things right, the consultant or the inpatient admitting doctor will simply have to continue the care of the patient that you initiated while in the emergency department, or whatever floor or service you are on. If you're at a place that requires you to get admission information, be sure to get that before you hang up the phone. When I first started working in the emergency room, I would actually write up what I would tell the consultant or the admitting doctor. That way, all I would have to do is read off what I was going to sign out to the other doctor. And if I ever got interrupted, I would immediately know where I would need to resume my presentation. Which brings me to another point. Don't let your consultant constantly interrupt you. If you feel like you're being interrupted a lot, it's okay to nicely ask them to wait until the end of your presentation and that you would then be happy to answer a few questions. Remember, this is not a presentation like you are on the inpatient wards rounding. This is a sign out. You've done your part and it's time to pass the baton on to the next physician. Another important tip is to always take a second before you place your call to think about what questions the person on the other end of the line could potentially ask you. At the hospital I work at, the residents will sometimes try to shuffle patients between the cardiology service, GMED service, or PCU service. If this is the case at your place, be sure to have an ironclad answer when that question inevitably comes up. Remember, you're not trying to lie or make the patient out to be something that they're not. You have performed a full assessment of this patient. You spent time with them, you've worked them up, and you've determined with the best of your ability that this patient needs to be admitted to a specific service or that they need to be consulted on. So express that precisely. Don't falsify information or lie about your patient. Be honest, sincere, and precise. And that's it for this lecture. Please let us know if you have any additional tips when calling up admissions and consults.